Razvi. Dr. Salman is a consultant and senior lecturer of endocrinology in Newcastle University in UK, United Kingdom. He has more than 80 publications. His special interest goes with the subclinical hypothyroidism, especially in the elderly, regarding its cardiovascular effects and clinical outcomes. He is going to address the topic of managing subclinical hypothyroidism in the elderly. So go ahead, Dr. Salman, you can start now.
Right. Thank you very much, Tamer. It's a real pleasure and a great honor to be here today with all of you. Ideally, we would all meet physically, but as we were talking before, the pandemic has made sure that we'll stay put where we are for the next few months anyway. So this topic of hypothyroidism or subclinical hypothyroidism in the elderly has become slightly controversial over the last few years, as it has, I suppose, across all the different age groups. It's always been controversial, and I'll try and cover that in the next 20 minutes or so. Let me share my screen. Okay, so what about hypothyroidism or subclinical hypothyroidism in the older person? Where are we currently? What is the current thinking? All of us have been, practicing for some time, but not all of us, but most of us, I suppose. And we tend to carry a baggage of what used to be done 10, 15, 20 years ago, maybe. But things evolve in medicine, as they always have. And the state of evidence is in a flux. So, the first thing I'd like to point out is that we should always look at the patient. There's a tendency amongst a number of people to look at blood results, and the art, especially with the pandemic and telemedicine and video conferencing and also on, it's much easier just to look at a blood result and adjust the dose of medications. But however, medicine is not just about managing numbers. If it was, a computer can do it. You don't need a person with experience and knowledge to be able to take a holistic view of the patient. So the biochemistry, the thyroid function is a guide. It's not the end-all and be-all of our management, and certainly not a binary treatment aid that you look at it and decide whether you should treat or shouldn't. And it's really important to find out when we talk about abnormal results, because this is true for everything, including thyroid function. How do we get the normal reference range? And this is really crucial. What we have is a statistical tool. We look at 100 or more people and class them from low to high, and look at the middle 25%, 95%. And those 95% are classed as being normal. Is that clinically valid? No, it isn't, because we don't really have a clinical role for this. So the top 2.5% are deemed as high, and the bottom 2.5% are deemed as low. So in the context of TSH, the top 2.5% would be deemed as subclinical hypothyroid, and the bottom 2.5% would be deemed as having subclinical hyperthyroidism. So the thing to keep in mind is that it depends a lot on who these people are. So the majority of people in the literature from whom the reference range has come from tend to be young, fit, healthy students or adults, and they generally tend to be medical students for ease and for convenience. So it's really important that we keep that in mind. So if you use that, the generally accepted upper limit of the TSH reference range is between 4 to 4.5 in adults. We're not talking about pediatrics yet. We will in the next hour or so. The other thing to keep in mind is that TSH isn't a fixed value, that it stays at one level over days or even weeks. Within a day and within a few days or weeks, it can change. And there are a number of factors that can affect the TSH. Here at the top, these are factors that might affect the TSH results, such as interference with the assay. In people on levothyroxine, things that interfere with the absorption. Plus, a higher TSH is seen in people who are obese, particularly with morbid obesity. Here, you'll see age is an important factor. TSH tends to be generally higher in women. In people who take calcium, iron, or iodine supplements, it tends to be higher. People who drink soya or eat soya tend to have higher TSH, rheumatoid factor, macro TSH, HAMA, which are heterophil antibodies, autoantibodies against TSH, all can affect TSH assay and cause a slightly higher level to be reported in the lab. Lower TSH is seen in people who take metformin, in pregnancy due to the effect of the beta-HCG, people of certain ethnicities, of Afro-Caribbean origin, people on alemtuzumab, dopamine agonists, steroids, rexinoids, proton pump inhibitors, interferon alpha. It's not an exhaustive list, but just to give you an idea. Plus, in the middle here are certain drugs that can affect the TSH in both directions: lithium, amiodarone, endocrine disruptors, and this factor here, the timing of the sample. TSH tends to have a diurnal variation, highest just in the early hours of the morning and lowest in the afternoon. So all these factors tend to have a role when we look at a TSH level. The upper limit of TSH has been argued about for at least 15 to 20 years now. Here I show you a debate that was published in JCNM 16 years ago now, where one group argued that the TSH reference range should remain unchanged, whereas another group was arguing that we should have a narrower reference range, and they argued that the upper limit should actually be about 2.5 for everyone. So this debate about whether it should be 4 or 4.5 or 2 and 6 has been going on for years. It's not a new thing. And it still continues. Recently, when I say recently, a couple of years ago, based on more recent data, Ann Coppola argued in an editorial in JAMA that the TSH reference range should be changed in older patients. And she was arguing that the upper limit should be much higher rather than lower. So this continues to be the case. What about, why is it an important factor? So subclinical hypothyroidism has been associated with symptoms and impaired quality of life, higher risk of cardiovascular disease and heart failure, obesity, subclinical hypothyroidism causing the obesity, that is, impaired cognition in older people, worse pregnancy and fetal outcomes in pregnancy, progression to overt disease has been another factor, and subclinical hyperthyroidism, which we won't cover, but I'll just briefly mention, osteoporosis, atrial fibrillation, dementia, cardiovascular disease once again, and also progression to overt hyperthyroidism. So all of these are the associations. Now, think carefully. When I say associations, that's an important word. Associations do not mean causation. So for example, I mean, this is kind of not very scientific, but I just show it to here to highlight how statistics can work. So on the x-axis, you have the number of sunglasses sold. On the y-axis, you have ice cream sales. So by the look of it, the number of sunglasses, as they get higher, the ice cream sales also get higher. And you think, well, you know, is ice cream sales influencing sunglasses, or sunglasses causing increase in ice cream sales? Well, the answer is neither of them. This is just a relationship which is being influenced by the third factor, which is heat. So the more sun and heat there is, the more number of sunglasses and ice cream sales will increase. So I think it's an important factor to keep in mind that associations do not always mean causation. Very, very occasionally, association can mean causation, but the vast majority of time, it could be mediated by something very, very different, which you are not even measuring. So let me ask you a question. Some of you may have answered this previously. 80-year-old gentleman with sustained subclinical hypothyroidism with TSH levels of 6.5 and 6.8 on 2 separate occasions, at least 3 months apart. Here is the reference range. The upper limit is 4.5. So based on that, the TSH is slightly high. Free T4 levels are normal. Reference range is here. And who's experiencing tiredness? The question is whether he should be treated with levothyroxine to improve his symptoms. So some of you, as I mentioned, may have answered this before. The reason why I mentioned this is we asked exactly this question to a number of endocrinologists across most parts of the world, including North Africa. And Tamer was very, very helpful in distributing this. So some of you may have actually answered this already. So thank you if you were one of those. And we looked at the responses and by different regions. So what you'll have here in the dark are people who are aware of guidelines about management of subclinical hypothyroidism. And the white here are people who adhere to those guidelines. And here in the gray, lighter gray, are the percentage of people who would treat this person who's 80-year-old with tiredness with marginally raised TSH. So what is interesting, I suppose, is for North Africa, South Africa, Europe, and most other regions of the world, roughly about 15 to 18% of endocrinologists would treat this 80-year-old person. What is interesting is that about 10% of people or endocrinologists in Latin America would treat this person. But what is important here is 25%. So much, much higher than other parts of the world of endocrinologists in North America would treat this person. Now, this didn't include general practitioners. So I would imagine, I don't know, but I would imagine the numbers would be much higher for general practitioners in most areas. Again, I haven't got that data, so I wouldn't know. But I would imagine it'd be something similar if that were to be the case, although higher for each part of the world. So the European Thyroid Association formulated guidelines for the management of subclinical hypothyroidism. This was 6-7 years ago now, or 8 years actually. And this was published in the European Thyroid Journal. And we came out with a really simple algorithm. And here, the age of the patient was the primary determinant of which pathway we went down. So it's arbitrary, whether we use 65 or 70. The definition of old age isn't set in stone. My own definition keeps changing every year. Every year it tends to get a bit higher. So 70 is what we used. So less than 70, the TSH is less than 10. If they've got symptoms of hypothyroidism, then a 3-month trial should be tried. If the TSH is greater than 10, then they should all be treated, is what we said. If the age is greater than 70, and if the TSH is less than 10, then the suggestion and the guidance was to observe and repeat the thyroid function in 6 months' time. So as per the European Thyroid Association, this person who's clearly above the age of 70, whose TSH is less than 10, should have just the TFT observed. If they progress and the TSH becomes 10 or more, then consider levothyroxine if they have clear symptoms of hypothyroidism. And again, that is a problem, because what are clear symptoms of hypothyroidism is very difficult to define. Tiredness could be due to any number of reasons, especially in that age group. What about the American Thyroid Association? Their guidelines are even older, 2012. published in Thyroid. And what they say here, and I've highlighted this here, is that treatment should be based on individual factors for patients with TSH levels between the upper limit and 10, and should be considered particularly if patients have symptoms suggestive of hypothyroidism, positive TPO antibodies, or evidence of atherosclerotic cardiovascular disease, heart failure, or risk factors for these diseases. Make a note, they don't mention age here in these guidelines. So I would imagine that if the ATA were to revise their guidelines or update their guidelines, that might change quite a bit. In the meantime, what we are seeing is that prescriptions for levothyroxine seem to be going up and up and up. Across most parts of the world, we haven't got data for elsewhere, but the data for 2 countries we have, the US here at the top, it used to be the 4th most prescribed drug, and currently is the top most prescribed drug. In the UK, it was the 3rd most prescribed drug, remains the 3rd most prescribed drug, but as you'll see here, it is going up in parallel across both countries. And it's very likely that it's similar in most other countries, including in the country where you are. What about hard evidence, randomized controlled trials? So this is an amalgamation of 2 trials, the TRUST trial and the EMO trial, that had very similar protocols, but they're recruiting separately in different countries. So they've amalgamated the results and published it together a couple of years ago. And to cut a long story short, what they find in this pooled analysis from 2 randomized clinical trials that had 250 participants aged 80 years and older is that treatment with levothyroxine compared with placebo was not significantly associated with improvement in thyroid-related quality of life, hypothyroid symptoms, or tiredness. So if you had an 80-year-old as part of a randomized controlled trial, double-blind, placebo-controlled, and so on, hard evidence over 12 months suggests that treatment will not improve their quality of life or symptoms. So their conclusion was, these findings do not support routine treatment with levothyroxine for subclinical hypothyroidism in adults aged 80 years and older. So this is some hard evidence that seems to be emerging recently. This is a meta-analysis of the various randomized controlled trials for quality of life, published 3 years ago. Now, this is not by age, but what I'd like to highlight here is the STOT trial, which is the biggest contributor to this meta-analysis, 81% for quality of life, 75% for thyroid-related symptoms, and 100% for fatigue here. And what they find is that across the randomized controlled trials, there is no evidence that treatment will improve quality of life, thyroid-related symptoms, or fatigue in all the trials, including in ones that exclusively recruited older people. The other thing also to keep in mind is that, as I said previously, is that TSH isn't a fixed molecule that will stay at its same level over years. I've got 3 randomized controlled trials here. The first one here on the left is the TRUST trial, where we not only see that TSH reduces with levothyroxine, as it's meant to do, but it also is a little bit lower after 18 months in the placebo group. So it starts at about 6.2 at baseline and ends up at about 5.5, 5.6 at 18 months. So the trend is it just go down. And this has been shown in other trials here. So this is the PARL study from the Birmingham Elderly Thyroid Study, where we see that in the placebo group, at 6 months, roughly a third of people had normalized their TSH, and at 12 months, half of the total participants had normalized their TSH. In another study, which recruited older people as well as younger people. In the placebo group, roughly at visit 6, the median TSH starting from 5.7 was actually 3.2 to end with. So we see this reduction in TSH across various different trials. So a slightly high TSH will not stay high for every person, and for the majority will actually reduce. Whether it normalizes the most or not, we don't know, but randomized control trials suggest that it will normalize in about 50% at least. The other risk of treatment, I suppose, is that excessive thyroxine treatment as well as low TSH or low thyroxine treatment are very, very common. So in most studies, excessive treatment has been seen in at least 15 to 22% of all patients in primary care. So excessive treatment is not uncommon. The other thing to keep in mind is that, again, this is an association. So areas in the UK that have higher prevalence of hypothyroidism, and by that I mean the definition is people on levothyroxine treatment. So areas in the UK that have higher levothyroxine treated proportion of people. So here on the x-axis, here are areas that have 2% of the population that is on treatment, and on the right-hand side is about 4.5% of the population that is on treatment with levothyroxine. We see that the prevalence of atrial fibrillation follows a similar positive course. So the prevalence of atrial fibrillation tends to be higher in areas that have more levothyroxine treated people. Now again, it's an association. I don't for a second suggest that it's the levothyroxine that might be causing it, although it's possible, but something just to keep in mind that it might be being associated with adverse effects. What are the potential deleterious effects of excessive levothyroxine? So if we argue that a TSH of 5, 6, or 7 is normal in an older person, then any treatment with levothyroxine clearly is going to be excessive T4 for that person. And what that could do, it might have effects on bone mineral density, and particularly in older people where bone mineral density in women especially, where BMD is lower to start with, more levothyroxine could, or excessive levothyroxine could be worsening osteoporosis and potentially causing fractures. And similarly, in older people, the risk of atrial fibrillation is higher. Excessive T4 could also be leading to higher risk of atrial fibrillation. So this is something just to keep in mind. What about observational studies? So this is a study from Scotland that suggested that a suppressed TSH is associated with higher risk of cardiovascular admissions. And there's the hazard ratio here, which is all greater than 1. Atrial fibrillation or related death, which is again higher than 1. Osteoporotic fractures or related death, which is almost double. So again, suggesting that chronic long-term treatment with levothyroxine, when associated with a suppressed TSH, is associated with hard adverse outcomes. Now, some of you may have seen this. This was a clinical practice guideline that was published in the BMJ a couple of years ago. And I was talking about this with Tamer a few minutes ago. This is a visual summary of the recommendation. And I'll bring you right to the bottom. So this says a strong recommendation. And they compared no thyroid hormone versus levothyroxine in people with subclinical hypothyroidism. And they recommend that thyroid hormone therapy shouldn't be used in patients with subclinical hypothyroidism. And what is important is that their definition of subclinical hypothyroidism was TSH up to 20 milliunits per liter. This is slightly controversial because I'm not sure where they got the TSH of up to 20 from. I'm not aware of a lot of data that uses TSH of 20. There's a lot of data and guidelines about 10, but 20 is slightly over the top. So if you, and this is across all age groups, so imagine a 22-year-old lady with a TSH of 18 who's feeling extremely tired and has no other reasons. If you follow this guideline, you wouldn't treat her. But I have certain reservations about this. So therefore, this is my view. You're free to look into it yourself. The other thing also to keep in mind is that there are other common reasons for high serum TSH. We looked at that previously in the first few slides. Obesity is associated with a high TSH, and it's actually the obesity that resets the hypothalamic pituitary axis. So TSH levels are higher. But what's important is that it's not levothyroxine that's the answer, weight loss is the answer. And after weight loss, particularly in bariatric surgery, we find that TSH levels normalize in roughly 3/4 and up to 80% of people with mildly raised TSH levels. So it's not the hypothyroidism causing the obesity, it's the other way around. Iodine intake is another factor. So there's good data from China that's coming through that suggests that as iodine intake goes up, TSH levels increase, and therefore subclinical hypothyroidism prevalence also increases. And as I mentioned before, keep in mind the diurnal variation of TSH. If you measure somebody's TSH at 5 in the morning, particularly in a hospital, the number of people with a high TSH you'll find will be much higher. Whereas if you were to check it later on in the afternoon, about 2, 3, 4 p.m., you will find that TSH levels tend to be lower. So which older person should be treated is relatively simple. If they have a sustained TSH greater than 10, then think about it. I'm not saying they should be treated, but consider treatment, particularly if they have unexplained symptoms or they have a strong family history and so on. And a trial might be needed. So if they don't feel better after, say, 6 months, you could always stop it. And if the TSH is less than 10, if the symptoms of hypothyroidism persist and no other explanation can be offered, and you're really struggling, then again, a trial of treatment in this group may be something to consider. So to summarize, the association of subclinical hypothyroidism and various outcomes are not confirmed as being causal in most instances in this age group. A number of individual circumstances need to be considered, and not just the actual value of TSH. And age, I would argue, is one of the fundamental issues or factors we need to take into account. There are others that I've mentioned. High quality evidence is required to evaluate long-term outcomes. The trials I've mentioned, the TRUST trial, the EMO trial, have looked at patients up to 12 months, 18 months, but we don't really know what effect this will have, either good or bad, over 3, 4, 5, or even 10 years down the line. So thank you very much for your attention. I think we have a few minutes for